1 in 2,000 is a big number. You need to keep in mind that your baseline risk of developing cancer in your life is around 1 in 2 or 1 in 3. It uses contrast, less contrast than a cardiac cath, but still iodinated contrast. It has almost 100% negative predictive value. So if you have a coronary CTA in the ER and it's negative, you do not have coronary disease. The flip side of that is less straightforward. If you have a coronary CTA that shows the presence of disease, you might not have disease. Okay, so the positive predictive value is lower. The sensitivity and specificity, depends on what you read, is somewhere between 90% sensitivity to around 85% specificity, pretty close to nuclear stress testing. So what a lot of the trials have done is they've looked at, well, since it has such a high negative predictive value and a moderate positive predictive value, what the trials have done is they've looked at patients who have been low to moderate risk for coronary disease. If you have a patient who's high risk for coronary disease, if you have a patient who has an abnormal EKG, if you have a patient who has positive biomarkers, if you have a patient who's had caths done in the past that have shown disease or stents in the past, they're not a good patient for coronary CTA. Those are patients that you know already have disease, and you're not going to be able to benefit from that 100% negative predictive value because the patients already have disease. So the literature, which we'll look at in a little bit, Dr. Sinner's going to present to you, has looked at patients who have been low risk and moderate risk for disease. And most of the literature has taken these patients, and some of the studies have scanned all of them and blinded that to the hospital course. So come to the ER and you're going to be admitted, we'll do a CTA. We won't let any of the house staff or attendings know what the CTA shows. They'll let the house staff and attendings treat the patient. And then in the end, they'll compare what the CTA results showed compared to what traditional care showed. And some of the other studies have looked at patients who have had CTAs in the ER, looked at those that have had abnormal CTAs and kind of how they were treated down the line, looked at patients who have had normal CTAs and how they've been treated down the line, and kind of compared the event rates in both those groups, and compared the costs in both those groups, and the radiation exposure in both those groups. And the data has been fairly weak, and we'll, Dr. Sinner will go through that, and then we'll have a chance to talk about it. But before we even get there, the most important part of this test is choosing the right patient population. Okay, and what I'm going to argue is that the patient population that you want to choose is a patient who has an intermediate pretest probability of having ACS. Okay, so we see thousands and thousands of patients who come into the emergency department every year. Most of them do not have acute coronary syndrome. How do we know who does? The reason why we need to know who does is we need to know who needs to be admitted, obviously. We need to know who is going to benefit from a test such as CTA, which has side effects, radiation. So the best, there are multiple scoring systems out there. TIMI is one of the most proven. TIMI data comes from the thrombolysis in MI group. There are 30, 40, 50 TIMI studies, but in 2000, Antman published in JAMA this risk score that looked at two trials that were part of the TIMI group, looked at Essence, and looked at TIMI 11B, and those were two trials that were comparing enoxaparin versus unfractionated heparin. But what they did, and there were about 6,000 patients in both these trials, they had all this patient data, and they looked at all the patients who came through the hospital system, and they knew who came in, and they knew who left, and they knew who actually ended up having a diagnosis of acute coronary syndrome, and then they looked at a bunch of different variables to try to tease out which variables at presentation most accurately predict who's going to have acute coronary syndrome and not. And we're interested in that because we want to use our CT test on patients who are intermediate probability of having coronary disease. So what came out of the data is the TIMI score, okay? And you get 1 point for each of these, okay? So you get a point if you're over 65, you get a point if you have more, 3 or more CAD risk factors, which are hypertension, high cholesterol, diabetes, or smoking, or a premature family history of coronary disease. You get a point if you have a known prior stenosis of 50%. So we'll often see patients in the emergency department, or I'll often be consulted on patients who have had caths in the past, who've had like 55% RCA lesion, and it's been left alone, but we know that these patients have disease. Any ST deviation of a half a millimeter in more than one bleed. More than two or more anginal events in the last 24 hours. So sometimes you'll see a patient who will be like, no, I had chest pain 2 days ago, I haven't had since. But sometimes you'll see a patient who's like, yeah, I had some chest pain last night and I had some chest pain this morning. You get a point for that. Taking aspirin is a risk factor. Okay, so why is taking aspirin a risk factor? You could look at it as if someone's failed aspirin. So they're already on aspirin, yet they're still having chest pain. So taking aspirin is a point. And lastly, elevated cardiac markers. So if you have 0 or 1 point, so you're just 65 or you're 64 and you come in and you're having chest pain, this is a 2-week risk, okay? So this is a 2-week risk of having death, MI, or urgent revascularization because of chest pain. So if you have 0, 1, your 2-week risk is 4.7%, 2 points it's 8.3, and it goes up dramatically. So patients with moderate pretest probability are patients who have a TIMI score of 3 or 4. Okay? So anyone who has a TIMI score of less than 3 or 4, I would say, in the literature, I believe would support you should not do a CAT scan for these patients. In fact, most of those patients should be discharged from the hospital. The death rates in those patients, the risk of MI in a patient who has a TIMI risk of 0, 1, or 2 is exceedingly low. Something like 1%, 2% over a year. It's basically that of the general population. If you have a TIMI risk score of 5, 6, or 7, you should not have a cardiac CT. That's a patient who should go to cath. That's a patient who should be admitted to the floor, worked up in-house. It's the patient who has a TIMI risk of 3 or 4. And let me describe to you a patient who has a TIMI risk of 3 or 4. A 65-year-old patient with hypertension, high cholesterol, and diabetes, who's on aspirin, who comes into the emergency room with chest pain. They have a TIMI risk of 3. So their 2-week probability of having death, MI, or urgent revascularization is 13%. Okay? Throw into that one more score. I don't know, maybe they're taking aspirin 2, and then it's TIMI risk 4. So 20%. So if someone comes into the emergency room with a 20% risk of having an adverse event in 2 weeks, I want to know if that patient needs to be admitted or not. There's still a very strong chance this patient doesn't have coronary disease. If this patient doesn't have coronary disease, I don't want them. I want to discharge them and follow them up as an outpatient and modify their risk factors. That's a patient I would order a cardiac CT in. The cardiac CT would come back and you'll talk to us about how long it takes and what happens. The patient will come back after the test. If the test is negative, I can discharge the patient out of the hospital. If the test is positive, I'll keep the patient in the hospital and likely cath or do some other mucus study or rule them out. The important thing to realize, I think, that, in my review of the literature, what people will say in the studies is that patients who have a normal EKG and negative enzymes are low risk for cardiac disease. And we know from the TIMI data that that's not true, okay? So if you take off elevated cardiac markers and ST deviation, and you give someone points for everything else, you could still have a TIMI score of around 5. So you could be in the ER with chest pain, have a normal EKG, have negative enzymes, and still have a 26% risk of having disease. And you'd have a TIMI risk score of 4 or 5. That's all for my video.
Great. So I just want to reiterate, and you can correct me if I'm wrong. We're looking at patients TIMI 3, 4.
Correct.
And I think your last comment I was going to ask you about, ideally, and from the literature, and I just want to make sure, on the cardiology side, these are patients without significant EKG changes and with negative cardiac enzymes.
Right, so TIMI 3, 4. TIMI 3, 4, no history of CAD, normal EKG, normal enzymes.
Okay.
How about timing from last chest pain?
Depends. I mean, it depends where you're at. It depends on the rest of your risk factors. So if someone comes in and said to me, I had chest pain 2 weeks ago and has an elevated TIMI risk, I might not treat that the same way as someone who says, I had chest pain 2 days ago or, 36 hours ago.
I'm going to hold questions till the end. Okay, Michael. So then we're just going to pivot now to Dr. Scott, because getting the CTA is a little different than getting a pulmonary embolism CTA. Yeah, she's smiling and laughing. It actually is pretty involved on the radiology side, so I'm going to let her describe. you might get phone calls saying this patient can have a coronary CTA. And there's a lot of kind of steps leading up to it. So it is logistically involved. So I'll let Dr. Scott take over.
Yeah, I just want to thank you guys for having me here. I also want to say that Dr. Wade, who's really our cardiac imaging specialist, could not be here today, unfortunately. But I can sort of give you sort of a broad general idea of what it's going to involve, and he really is the expert. I also want to say, just historically, since I've been a resident here, Dr. Wade has been trying to do cardiac imaging here at county and at downstate. So he's very excited and happy that with buy-in from cardiology and with emergency medicine involved, that we can actually see finally his dream realized. So very happy about that. That being said, I want to talk about where we are now and where we need to be in terms of radiology's readiness for this new venture, so to speak. We currently, you guys know, we have a 128 slice scanner, which is excellent, and unfortunately did not have the software for cardiac imaging when the machine was installed. That is being rectified. We're getting the software that's necessary to do the imaging, and shortly, hopefully that will be installed. Okay, so that's one issue. We definitely have the hardware. It's also going to be an issue of our techs ready to perform this imaging. And I think that's probably one of the biggest obstacles we're going to face at this point. And the answer is yes and no. I mean, I guess technically some of them have been trained, but the fact of the matter is that they have not been doing it. And so because they have not been doing it, I don't know if they ever really got an opportunity to really do a study and see if they really know how to do it. So I think that's one of the major issues that we're going to have to address in the coming weeks and months. That also being said, we have to talk about, in terms of a radiologist, just like Dr. Willis mentioned, it's not like ordering a PE study or a dissection study. It's very involved and it requires a lot of pre-imaging screening and work. So we need to talk about nursing availability and supervision. These patients, if they have cardiac rates of greater than 70 or so, would have to be given beta blockers. Some of them would also need sublingual nitroglycerin, and this is not something that, that can just happen like that. This definitely has to be supervised by clinical staff as well as radiology trained staff. And also there's certain exclusion criteria. Of course, if the patient has elevated creatinine, the patient will not be able to have the study. And also if the patient has asthma, certain arrhythmias, or some other indication to beta blockers, they cannot have the study done. So basically what I'm saying is that this is a great point for us to agree that we have to start meeting regularly to get our protocol and to get our patient flow and all these things worked out. So between cardiology, emergency medicine, and radiology, there's need for strategic, multidisciplinary approach to this new program in order for it to be successful. What I don't want is for us to just start imaging and then it just become disastrous. So we really have to start setting target dates of when we want to see the program go live and start meeting regularly so we can address all these different issues from radiology point of view, from cardiology, from emergency medicine, and come up with our own inclusion-exclusion criteria, look at the specific parameters and protocols we have for our machine and see how we can best serve the patients. Also, we have the issue of post-processing, which is a huge issue. A scan takes very little bit of time. However, the bulk of time is going to come into reconstructing those images, mapping those coronary arteries, and it sounds simple, but it's a mammoth task. A lot of institutions do send their images out for post-processing and then give us back the data. Some, we're at the very infant stage, so I'm not sure what the institution will be willing to pay for and what they will be willing to allow. The alternative would be for the radiologists or the cardiologists to actually do their own mapping and do their own post-processing, which is extremely it just requires a lot of time and skill. So these are other issues that we have to talk about. And the other issue, of course, is interpretation of these studies. We only have one board-certified cardiac imager, that is Dr. Wade. I'm not sure in cardiology how many people are qualified to read these studies, but that is another issue that we'll have to discuss. And the availability of these people who are qualified to read these studies is something else we'll have to discuss. So I guess my point is that I'm very happy that we're at this point and that we need to all start meeting very soon and very frequently with specific targets and goals, because I don't believe in just meeting for meeting's sake, really. I don't like that at all. It's a waste of time. I think we have to be very strategic and determined to get it running, in whatever time we decide, and get buy-in from the institution to give us the support that we need in terms of nursing, in terms of post-processing, in terms of whatever else we need to get the program going. And that's basically the radiology perspective. We're willing and we're excited, but it's going to require a lot of planning and a lot of institutional support, which I'm hopeful that we'll be able to have.
Great. But again, I just want to reiterate, so to get this test done, the timing and kind of the identifying of the landmarks is more involved than a CTA. You have to time it for coronary infusion of the contrast, and their heart rate has to be below 70. So these are patients who are already tachycardic, may need to be beta blocked, so giving a cardioactive medication in radiology can be difficult or risky. And also there are other contraindications, and correct me if I'm wrong. Again, GFR, as always in CTA, BMI is a contraindication,
Yes.
I think over 40.
Yes, and it depends on the machine. And I'm not really sure what the specifications are, but generally over 230 pounds is
Okay. Which in some populations may not be that big of a deal, but in our population can definitely be a big barrier. And then the other one that I read about was stents, metallic stents.
Oh, we're going to talk about that.
Okay, so then I'll let Dr. Sanders answer. I want to make sure everyone knows that.
Is it both Kings County and UHB, or just Kings County?
Kings County for now. Kings County.
So what I'm going to do is review the 3 papers. There was the 3 papers that Dr. Willis gave out and an editorial, which I'm not going to review. But the 3 papers, the American Heart Association guidelines from 2010 about coronary CTA. We're going to talk about that meta-analysis from the looking at ED length of stay and costs with CCTA. And then the last thing is a review that has the operating characteristics of CCTA, and I'm going to do, what I always do, a little Bayesian analysis. So this is the American Heart Association for patients with non-acute symptoms, possibly representing ischemic equivalent. That's kind of hard to know what it means in emergency medicine. But this is, so for the chest pain, this is one of the groups of patients that are going to come to the emergency department that you're going to think about CCTA. And they recommend, if you have a normal EKG or interpretable, and they can exercise, and they talked with Dr. Levitt talked about that the most appropriate group is the intermediate group. And even if they can't exercise, still the intermediate probability group is the group. Now their intermediate group was a very broad range. They had from like 10% to 90% was intermediate, which seemed like a very broad range. I think Dr. Levitt's definition of somewhere between 15 and 20% is probably a better pre-test probability for when to use this test. And this is the more likely the patients that we talk about. They actually recommend, they say it's appropriate in the low pretest probability group, but we're going to see what they think of low pretest probability in some of the other studies is less than 10% probability. And that seems very, very low to do a very expensive, time-consuming test to do. So I agree with Dr. Levitt. I think the intermediate group is the best group to look at. The high-risk group, certainly, this is way past that. They should be admitted they probably need a cath. So we're going to talk about the next paper, which are the outcomes. So ED outcomes for CCTA. And these are the 4 studies, and I want you to look at the criteria they used to define low risk. Their TIMI scores on the average for these 4 studies will be between 0.8 and 1.29. This is very low. This is very low. They looked at an extremely low pretest probability, less than 10%, and it was less than 10%. I think we're going to look at the patients who got PCIs, about 8% in this population. And that was a much greater group in the CCTA than in the usual care group. So these are if you look at these patients, some of these you may not even be drawing, troponins on because the risk is so low. This is 12 hours from chest pain. Look, they go down all the way to age 25. This was a very, very low-risk population. And I think that these studies really don't have a home with us. I mean, I'll talk about them because they are people quote them quite a bit in the literature, is that there was a significant decrease in time. This is the usual care group, this is the CCT group. This is the usual care group was 15 hours, this was down to 3.4 hours. I don't see how they got this done, and I can't imagine us getting a CCTA, nothing personal. I just can't imagine us getting the troponin back, and then the patient beta blocked, then to CCT, then it read in 3.4 hours. So I think it's not us, and this is not the patients that we see. So I think this is a nice study, but I don't think it has anything to do with us. And I don't think we should be using it. There was some risks to doing CCTA, that the patients who got CCTA had a much higher risk of getting angiography and much higher risk of getting PCI or CABG. Now, what the study didn't do is because the numbers were so low, did these patients really benefit from the cath and the CABG or the PCI? There's really no data for that. So that if you looked at this as the cost, is the patients who got CCTA got a much higher rate of cardiac caths, and in fact, my favorite number is number needed to scan. So for every 48 patients that got a scan, one more patient in that group would have gotten the cath. So that's a big deal for the patient. And if you look at PCI and CABG, that it was 50. For every 50 patients who got a CCT, there was one extra PCI or CABG. Now maybe that was necessary, but we don't know because this study didn't do it. So I don't think this study, although it's much quoted in the literature, has anything to do with our patients, has anything to do with what we do in the emergency department. And there were no deaths in either group. That's because there were only just a few MIs, and they were basically during the index hospitalization. And there were too small numbers to really look at the data. And they didn't follow the patients. So I'm going to talk about the last paper, which is this paper in 2015 in Circulation, which talks about the operating characteristics of CCTA, how good a test it is. And we're going to spend some time on this. So 25% of patients are really, you can't do a CTA. They're too obese. You really have to beta block them. You really have to get their heart rates to 60 to 65 to see 80% of their coronary arteries. Really, less than 60 to see 95%. So again, this is a big issue about beta blocking these patients and getting them to the required heart rate at the right time for the CCTA. So this is not something we should be doing in Suite A. I think this test should be ordered by the cardiologists and should be done in definitely in a monitored setting. So you're going to take patients in moderate risk. They're going to have to be in a monitored setting to do this, to get their heart rate safely down. And they're going to need a lot of beta blockers. I think just one dose is not going to do it. And they can't have AFib, they can't have PACs or PVCs. And this is a very narrow group and a very complicated study. So let's talk about the characteristics. So this is the table. I snipped this out of the paper. So this is the operating characteristics of the CTA. And what I did was these were 5 papers. These papers weren't done looking at CTA. They were looking at something else and used CCTA as a comparator. And they had actually different probabilities of CAD, and they had very different sensitivities and specificities than the other groups. So I didn't include them in what I did. I did a quick meta-analysis of this, and I pulled the data. Also, this study by Menjboom had a significantly different results. I took them out as an outlier. So what I did is I compared Miller, Budoff, and Chow, and I did my usual meta-analysis, and I made forest plots. And if you pull the results, which you can in this data because they're pretty homogeneous, that the likelihood ratio of a positive test for a CCTA, and they used kind of a funny thing, they used greater than 50% stenotic lesions as their outcome variable. which I don't think you would fix anyone with 50%. But that's what they use. So they used a very low bar to say positive coronary artery disease. They used 50%. I think if we went out into the audience here, I think there'd be a number of you who have 50% that are completely asymptomatic. So I think 50% was too low a bar to use anyway. But even using that low a bar, the likelihood ratio for a positive test was 7.53. But as you know, my interest in the emergency medicine is who I can send home. And the likelihood ratio of a negative test is 0.16, which is actually pretty good. I mean, it's not bad. This is a pretty good operating characteristics. It's certainly better than EKG. It's certainly better than history and physical. You know, it's certainly better than a lot of the tests we depend on. So it is better than most of those tests for coronary artery disease using a very low bar cutoff for 50% stenosis. So what I did is, you know, I like this. This is kind of Fagan nomograms, and you've seen me do this many times. So what I did was I said, if you had different pre-test probabilities, what would be the result of the post-test probability for different levels of pre-test probability? And for 10%, this is the lowest group. If the test is positive, you go from 10 to 50%. Well, that's significant. You probably want to study those patients. If it's negative, it goes down to 2%, which is what we always say as good as you get, is 2%. So for the pretest probability, for the low group, for 10%, I don't even know if you would study these patients to start out with, but you could get down to very low probabilities. For the intermediate probability, I used the weighted pretest probability for those 3 studies. So although the American Heart Association says, you know, 10 to 90%, I chose a medium range, but it's actually turned out to be a higher range than Dr. Levitt. If we use 20%, you get something that looked like that, which is pretty good. But at 40%, if it was positive, it goes almost up to 90%, but if it's negative, it still gets to about 10%. So for this level of pretest probability, it's probably not good enough, and I agree with Dr. Levitt, you probably have to have somewhere in the range in between, about 20%. Greater than 10%, but less than 40%, which seems reasonable. Now for the 90%, it certainly is not a good test, because if the pretest probability is 90% and the test is positive, well, it goes almost 100%, which is not surprising. But the post-test probability of a negative test comes down to 60%, which is not reasonable to do anything with. It didn't really help you. So for the high pretest probability, it doesn't make sense. For the very low pretest probability, you're probably not going to study those patients anyway. So I think I agree with Dr. Levitt. It's that some group in between here is the intermediate probability is probably the best group to do. So in conclusion, I think that the studies that show that meta-analysis about ED cost and ED length of stay, I think looked at only the very low pretest probability, which doesn't really make a difference to us anyway. And I think it's the intermediate pretest probability, about 20%, somewhere between 10 and 20, 30% is the group that we should be looking at. And that's it. Thank you.
So I do want to open up for questions and commentary. I'm going to first ask if Dr. Xavier or Dr. Jackson want to make any comments in terms of the operations of this in the ED, and then specifically also in how this might work in terms of the observation unit, which I agree with Dr. Sinnott. Some of the papers that said length of stay would maybe go down to 3 hours is not likely. A lot of the other papers talked about a difference in stay from 18 hours to 25 hours, and that seems to be kind of in our range of an observation unit. So I didn't know if there was any commentary about how, if that would be part of that process or how we were thinking about doing that.
Yeah, I mean, if you look across, and I don't even compare the Sternberg, but I know of in the newer metro area. Most of these patients, and I agree, the low risk doesn't seem to be, from a cost-benefit ratio, doesn't seem to not going to benefit the patient at all. And I think we need to do due diligence as well with our population to find out what the payer mix is, who's going to pay. Because I think we can do things and that's all good, but if we're going to leave patients with huge bills, then we're not really met, the patient's needs at all. So that's like in terms of doing our duty to make sure that this is the right test for the right patient at the right time. That's part of what we have to look at. ideally, those are patients who's going to be in observation for obvious reasons. They're the intermediate risk, most likely, and they're going to need time to be prepped once you rule them out, and they're going to get test takes a while to for reconstruction and the results. The average time I think is about sometimes 6 to 8 hours. That's a long time for a patient to be just in a ED without a disposition, waiting for that test. So ideally, those patients will be in obs. And because we also have the monitor that we need for those patients, and we have the nursing, and we most of the time we'll have the nursing resource for those patients. So that's where this is coming from. Ideally, too, though, one of the challenges I don't think we've talked about yet is timing, right? And ideally, weekends will be great to have this study if the patient fits the criteria, because right now, that's part of the challenge. I don't think that's something we're going to be able to execute soon, again, because of the environment we're in terms of cost and resources from the hospital level. But those are the intermediate risk is what we're really looking at that can benefit. A lot of due diligence, look at the cost to patients to make sure the insurance companies will be paying for those. And observation is the ideal disposition for the patient who meets those criteria.
Thank you. So I'd like to open up questions and comments. Mike, do you still?
Yeah, I had a question for Dr. Levin and Dr. Spencer. Dr. Levin, in terms of the TIMI score, I get that two questions actually. The 3 TIMI score 24 is kind of our intermediate risk, but that's not including if they have a known stenotic lesion already, because then we already know they have coronary artery disease,
Right,
correct? So we
right.
shouldn't actually.
So TIMI 3 or 4, no CAD, normal EKG, no
Right.
enzymes.
But I'm just saying one of the TIMI scores is no disease,
Correct.
right? So that's
Right.
okay.
Right.
And then we actually use a lot of heart score. I don't know if you have an equivalent score on the heart monitor.
Yeah, I mean, they're all validated more or less. If you look at the guidelines, they don't recommend one score over another, but I can look at the heart
it's
score,
still
and
intermediate.
if you guys are more comfortable with that, as long as their intermediate is around like what Dr. Sinner said, I think that's fine.
Okay.
Yeah.
And then for Dr. Center, the data that you presented, can you clarify? So the research showed that actually doing this test led to more cats? Was that what happened?
Oh, definitely.
Because they have,
Because they had low high calcium loads.
right.
So what do you do?
And that's the problem with CTA. Right? We said that a positive CTA doesn't necessarily mean you have disease, whereas a negative CTA is very powerful or
Right.
very strong. So if you take a patient with a low pretest probability of having disease, they have a positive cardiac CT, there's a good chance they don't have disease, but you'll probably order a cath because the CT report will say, can't rule out a 60 to 90% proximal LAD lesion. And then, what do you do?
Because it doesn't determine flow. It's anatomy, right? So that's the problem with the CCTA. It just tells you, right.
Yeah, which is a good point. It's not a functional test. It's not like a nuclear stress test where you'll actually, be able to see ischemia, or a stress echo where there'll be ischemia. It's like a cath where you'll see there's a 50% blockage or a 70% blockage, but you don't know if that's functional. You have to then, there's data saying that 75 or 80% lesion is usually associated with ischemia.